Dr. Gary Turnbull is the principal of the Lincoln Institute, a boutique leadership development company which delivers facilitated training and coaching to a broad range of industries, including the veterinary profession. He is a highly recognised and respected speaker and facilitator in the fields of veterinary practice management and leadership, veterinary business models, and life balance strategies. Gary delivered the 2015 AVBA On the Move series, Leading Change in Your Practice. He also developed the Goldmine Veterinary Dental Program, which he has presented internationally. Gary is also the director of the Eastport Veterinary Hospital, a multi-award-winning and Australian Small Animal Veterinary Association accredited hospital of excellence, situated on the mid-north coast of New South Wales. He's a first-class honours graduate from the University of Sydney and a chartered member of the Australian Veterinary Association. He is also a member of the Australian Small Animal Veterinary Association, the Australian Veterinary Business Association, and the Australian Veterinary Dental Society. Gary is married with 3 children and he resides in Port Macquarie, Australia. Thanks very much for coming this evening, Gary, and we look forward to hearing what you've got to say.
Thanks, Jeanette. Thanks for the introduction, and welcome everybody. Thank you for those of you who have given up your time after no doubt a long day in the practice, so good on you for coming on board. For those of you that aren't making it live, well, we hope you obviously pick up the recorded version soon thereafter. So tonight we're going to talk about, in this series of good medicine equaling good business, focus on small animal dentistry and what does that mean to our practice from a clinical perspective, and then how does that relate from a business sense as well. So that's what we're going to talk about. It won't be overly clinical, although there will be some clinical aspects to it, because I really think it's important we focus on what does it mean from a business perspective. From a historical point of view, my interest in small animal dentistry was sparked probably about 10 or so years ago, and it all came about through a conversation with Mark Ethel, one of the principals of the Canberra Veterinary Hospital, and he happened to say to me at a conference, "Gary, have you started doing $150 dentals yet?" And I was mortified. The thought at that time to me of doing $150 dentals was just unthinkable, and I said, "You've got to be kidding. I'll never do dentistry for $150. And at that time, we're going back quite a number of years now, it was probably 2007 that we had that conversation, and at that time, our probably most basic dental procedure, so a routine scale and polish, at that time was probably being charged out for maybe around $350. So $150 seemed a massive step backwards and something I wasn't interested in. What I didn't really appreciate at the time, and it was through learning and understanding, that effectively there was an enormous number of cases that required dental attention that we were simply failing to recognise and failing to treat. So once I understood my dentistry better, then I was able to put that $150 dental, as it were, into some context. And I'm going to put that into context for you tonight. Having sort of developed an interest in dentistry, I started working very closely with IM3, and we developed some years ago now the Goldmine In Your Practice DVD, which is really just an educational DVD for practice owners and practice staff on how to think about dentistry differently and how to really get it up and running in your practice. And that DVD to this day is available through IM3. They'll happily, it's complimentary, they'll happily shoot it out to you, and I do recommend having a look at that because there's some really good information there as well, and of course you can look at it at your leisure. So we started embarking on improving our dentistry in late 2007, 2008, and have spent many, many years refining that, and got it to a point where in 2011 I was invited to present that to Banfield Pet Care in the US. I I'm not sure how many of you are familiar with Banfield Pet Care in the US, but they are a corporate that owns around about 900 practices. So fairly influential. We're talking very significant numbers of veterinarians, clients and patients. And so I spent some time with them in Portland, Oregon, teaching them what this sort of goldmine veterinary dentistry was all about. So if we start out really, I guess question one is why dentistry? Why would we focus on dentistry? And the most important thing I think here is to recognise that we need to know how many patients walk through our door already suffer from some form of dental disease. And that information is widely available and published and recognised at 80%. So if you're looking to do a better job with your patients, if you're looking to care better for your clients, and from the context of an AVBA webinar, if you want to grow your business, it's walking through your door all day, every day. When you consider that 4 out of every 5 patients have some form of dental disease, I would ask you or challenge you right now, how many of those 4 out of 5 are you recognising and doing something about now, and how many are walking straight back out the door again? So there is, and I saw many years ago, an enormous opportunity to not only improve the quality of the practice that we were providing to our patients, but also I could see quite a massive financial or business opportunity as well. And that was, both of those things drew me down the path of dentistry, or focusing on dentistry. So if we think first about what do we actually see in small animal practice in dentistry? Well, by far and away the most common thing we see, without doubt, is periodontal disease, both in feline and canine species. And we're going to talk quite a bit about periodontal disease and its management tonight. We see malocclusion. In fact, we probably see malocclusion multiple times a day, every day of the week. I think my observation working with practices all over the country is that we're not very good at recognising malocclusion, and we're certainly not good at recognising the implication that malocclusion can have for a patient. It is significant. It can cause major endodontic problems for patients through their life, and it needs to be addressed, and often at a very young age. Thirdly, of course, endodontic disease. We see a variety of endodontic diseases. We see structural disease, like tooth resorption, and although that is more common in cats, it's certainly not restricted to cats only. We do see tooth resorption in dogs as well. Dental caries is seen in dogs. It's not seen in cats, but certainly you'd be surprised, not that it's particularly common, but it's there, and you will find it when you know what to look for. Trauma, oral trauma and dental trauma. Developmental conditions like persistent deciduous teeth are really common. Enamel hypoplasia is less common, and a whole range of other developmental issues. We see oral or paradental diseases like chronic feline gingivostomatitis and chronic ulcerative paradental stomatitis in dogs, particularly seen in the Cavalier King Charles Spaniel breed and Maltese Terriers. And then, of course, neoplasia, seen in both species with reasonable regularity, with, interestingly, like most neoplasia, the whole spectrum from very benign and relatively safe disease through to some of the most severe and aggressive neoplastic disease that we can see. So getting back to the why and the why focus on dentistry, and this is really important because if you're going to go to your team, and this is almost putting on leadership cap for a minute and taking dental one off, if you want to take this idea or any idea to your team, a lot of the motivation and the buy-in for them will come through the why. Why are we focusing on this? And it's very important to recognise that even if, as a practice owner or manager, some of your why is driven financially, that is not going to drive veterinary staff or veterinary teams, and in fact it can be a demotivator. So I think it's wise to try and keep dollars and cents off the table, and when we talk about the why, it's really all about being strong patient advocates, and also ensuring that we deliver for our clients when they visit us as experts, that we in fact act like experts and provide the best the best advice and recommendations that we possibly can for them. But it's also nice to look at what standards exist in the profession, and so part of the why is not really necessarily about you as an owner or a manager saying, well, we're doing this because we think it's a good idea, we're doing this because this is just the accepted contemporary standards of veterinary medicine. And one of the best guidelines there is the AHA dental guidelines. Now, you can go to the AHA website and you can download those, and I've just taken out a couple of pieces from those guidelines, which I think are really important. And AHA talk about performing unconscious examination on patients at least on an annual basis to be able to perform thorough oral examination, and also talk about dental checks on a 6-monthly basis to ensure that we're getting the results that we're looking for. So it doesn't have to be about us beating our chest and saying, well, this is what we think we need to do. We can simply say, if this aligns with our values, we want to provide the best possible care that we can, because it's in alignment with the gold standards out there that exist internationally. And very important from what is a dental program? And I don't like the word program at all, because I don't think it's wise to be thinking this as a program. The way to think of this is actually it's a culture, and it's a culture that aligns with best practice. And what we're looking to do is develop a culture around how we manage periodontal disease, how we feel about intraoral examination, and particularly the requirement for performing that in an unconscious patient, and also the requirement for intraoral radiography. So, I try and stay clear from this notion of a dental program, and just think about addressing dentistry appropriately and treating it at the best level that we possibly can. And I want to start by talking about periodontal disease. And to do that, we need to start with just making sure we're all on the same page in terms of what periodontal disease is and how we view that and how we stage it. So these are just a series of photographs that I've taken of patients of my own that I think really nicely demonstrate the standard grading for periodontal disease. And this is important as we talk about how we're going to address each grade. We need to know, again, and agree on what we're talking about. So the grade 1 patient is the dog or cat that has got plaque and tartar on their teeth. It's irrespective of the number of teeth involved. It's more about the level of disease in any teeth that are affected. And that plaque and tartar is at a level that is not causing gum disease at all, or at most what we call marginal gingivitis. So what we might see at the free gingival margin, which in dogs is that 1 to 3 millimeters, and in cats that 0.5 millimeter of loose gingiva that is not actually attached to the tooth, may show some early signs of reddening. But not necessarily. Certainly the patient that you can see in that photograph there, I would say has healthy gums, but considerable plaque and tartar there on the crowns of the teeth. As this disease progresses through to grade 2 and what we term established gingivitis, we now have increasing levels of plaque and tartar. And importantly, at the grade 1 level, the plaque and plaque bacteria were located on the supragingival tooth only. Now what's happened is, as we move to grade 2, we've now got the extension of bacterial plaque under that free or marginal gingiva to the subgingival region, and that is significant because we now have pathogenic bacteria closely related to the soft tissues of the periodontium. At this stage now, when you look at this photograph, and this is a nice representation, you can see that somewhat swollen and reddened margin there of the gums generally. And what we can say, and what is certainly accepted by the specialist veterinary dental community, is that red gums equals pain. Once gums get to that level of inflammation, they are sensitive. Does that mean a patient will show obvious overt signs? No, they won't, because they still have to eat to survive, and they will manage to do so despite that sensitivity there. And that's an important message that we need to convey to our clients as well, because their perception of well and healthy and as can be very, very different when it comes to oral disease and particularly periodontal disease. So at this stage now, we've got increasing plaque and tartar, we've got, if you like, a well-established gingivitis in the gum tissue, and plaque bacteria that are now subgingivally located. It's important to recognise, of course, at this level of disease, it is still what we term reversible. In other words, with treatment, we can restore and re-establish totally normal anatomy and physiology. Then we move on to grade 3 disease, or early periodontitis, and this is a massive step because we've now transitioned from reversible to irreversible change. And by irreversible change, we recognise that there is now some level of attachment loss between the tooth and the periodontal tissues. Now that may be in the form of periodontal pocketing, or it may be in the form of bone loss, alveolar bone loss. It may be in the form of gingival recession. But the reality is, and your pet owners, your clients need to understand that once their pet gets to this level, there is no going back, and that there will be permanent change existing in their mouth. So at this level now, further increases in the levels of plaque and tartar. There is an increasing shift in the bacterial population as we move through these grades from gram-positive aerobes to gram-negative anaerobes. So the bacterial population is becoming increasingly pathogenic. The gum tissue and periodontal tissues are starting to recede, or attachment to the root of the tooth is being lost. And as I said, there can even be early bone loss at this stage as well. Obviously, halitosis is getting a lot worse at this point in time as well. And then we get to the final unfortunate stage of the disease, which we have all seen and can be quite horrific, as you can see in this picture here, where we now have quite a putrid mouth. There is severe irreversible loss of periodontal tissues. There is very significant loss of periodontal or alveolar bone, very, very deep-seated infection, dramatic loss of soft tissue. There is tooth mobility often. There can be pus within the mouth. There can be abscess formation. It really is now at an end stage. These patients are suffering dreadfully, and suffer not only locally, but of course at risk of secondary systemic illness developing as well. So very important that we just understand those grades, because the way we treat the disease will vary depending on the grade that we're at. And the treatment options that we have available. So for our grade 3 and 4 cases, and this is probably no change to what you're presently doing, and that is that for your grade 3 and 4 cases, they require a combination of periodontal therapy plus or minus oral surgery. And by oral surgery, that will often mean obviously surgical exodontia, or tooth extraction, but it also may mean raising gingival flaps in order to give us better exposure or better access to exposed root surfaces for root planing and subgingival curettage, which is all part of the periodontal therapy process, not just ultrasonic scaling and polishing. For our grade 2 cases, and again, no doubt what you're doing already is that we deliver professional cleaning through ultrasonic scaling and polishing, plus some use of hand instruments for manual cleaning as well. But the area that you may not be addressing or may not be addressing effectively and in the number of cases that are demonstrating the disease, and that is to deliver the dental prophy for the grade 1 case. And this takes me back to my initial comments about the notion of $150 dental. And what I didn't understand back when I first heard that comment or that suggestion was that was referring specifically to grade 1 cases. And at that point in time, we simply were not treating grade 1 cases at all. And what I'm hopeful is that over the next 10 minutes or so, I can perhaps shift your thinking on how we address that situation, if not already. So the way we approach periodontal disease and the way we approach this, and what I've included within this webinar as well, is the scripting that we use with pet owners to help their understanding and to effectively, and I say this in inverted commas, to sell dentistry to them. Because the reality is as much as it may make you feel uncomfortable, if you're in the consult room in any capacity, you are in sales, whether you like it or not, because we are selling a diagnosis, we are selling treatments, we are selling health prevention, we're selling ourselves. So whether we like it or not, in inverted commas, we sell all day, every day. So what we have done over many, many years is refined the scripts, if you like, or the terminology that will really have the greatest influence on pet owners to ensure we move them to action. So the approach is that every single patient that comes through the door with grade 1 disease, in other words, if they've got plaque and tartar on their teeth, we are going to deliver a dental prophy. By that, an ultrasonic scale and polish under general anaesthesia. This is not a painful procedure, so we're not looking at surgical planes of anaesthesia, nor are we looking at you know, local anaesthesia either in these cases, of course. And I mentioned earlier that we were trying to develop a culture around 3 things: periodontal disease, intraoral examination, and intraoral radiography. And so part of this whole process is not just about cleaning teeth. The idea that every patient with grade 1 disease is that we will first perform a thorough oral examination, because the reality is that we don't know what's going on until we get in there. Let's face it, if we consider a lot of cats just don't like having their mouth examined at all, so we get, you know, nothing more than a glimpse of where they're at. And with the 42 teeth in the adult dentition of dogs, often there's at least 8 or more teeth that we can't even see in the conscious patient. So we can't possibly comment on exactly how their dental health is. So it's not just about that cleaning process, but it's about a thorough examination as well. And so the way we talk about this with clients is say, what would you do if your dentist said, you've got plaque and tartar on most of your teeth. Once your gums become inflamed and painful, we'll do something about it. And that's really the situation. So if our grade 1 patients come in and we fail to have that conversation with our client and we send them back out the door without acting, without proactively doing something to treat that level of disease, then effectively this is what we're saying. We're saying that it's okay to have plaque and tartar on your teeth. We know it is inevitable that is in time going to lead to gum inflammation. We can't stop that. It wouldn't matter what you do. In a conscious patient, you cannot remove the bacterial plaque that is already there. So I would challenge anyone who says, well, if I see a patient with plaque and tartar on their teeth, I get them started on a preventative program. There's two problems with that. Number one is the preventative program is not going to get rid of what's already there. Number two, we still don't know exactly how their oral health is because we haven't examined them fully. Now, what if a patient happens to have some significant disease in an area that we can't see, and we're now encouraging clients to brush their pet's teeth or have them chewing on products that are designed to make them chew? What we in fact may be doing is worsening the problem for the patient by increasing their level of discomfort and in fact driving them away from that form of prevention for the future. So it simply isn't good enough to say they've got plaque and tartar, let's start some form of prevention. We need to assess their level of disease. We need to correct whatever level of disease they have right now because they will start to suffer. It is inevitable, and we want to make sure that doesn't happen. So that's point number one. Number two, following treatment of all grades of disease, so whether they come in as a grade 1, 2, 3 or 4, once we've treated them, we'll then start them on a program of 6 monthly complementary dental checkups for the rest of their life. Now, whether that's complementary or not is really up to you and your practice. That is something that we have done at Eastport Veterinary Hospital. It's been very, very successful. The dental checkup is a relatively short visit, and we feel that it's well and truly justified and pays for itself, so to speak. However, if you feel very strongly that if someone is taking up some of your staff's time, then they need to be charged for that, then that's fine also. It's really what aligns with the values and the police systems and the culture of your own practice. The key is that we get people started on a 6 monthly dental checkup program. And the reason for that is that we know that this disease is going to recur. And the reality is that within 24 hours of professional cleaning, bacterial plaque will start to reform. And it's very important that we share this information with our clients so we set expectations for them. What's dangerous is that we either correct the dental disease that exists in a patient at any level and then say to the client, okay, great, well, we're all done now, good luck. Because if we see them, let's say, only annually at vaccination, we could have well and truly have a patient gone from perfect oral health to grade 2 or more disease developed within that 12 months. So we would be really doing that patient and client a disservice to let them get to a point where they're back to sensitive, uncomfortable gums because we failed to check in and address the condition before that happened. So it's very, very important for those 6 monthly checkups. What it also does, it creates a focus for the client. They start to understand that this is a disease that is going to come back. It's not a case of we've treated it, we've fixed it, and it will never happen again. And I have seen that before where clients have been quite disheartened because we'll examine a dog's mouth and say, well, look, they've got dental problems that we need to address, and the client might say, oh, well, my last vet fixed that. They said that they treated that. So very important to set clear expectations for the client. They need to know up front that this will come back. It's not a case of if, it's simply a case of when, and we need to manage their expectations around that. And the way we script that with clients, because initially some might say, well, gee, every 6 months. And so we need to monitor regularly. Most people require a scale and polish every 6 to 12 months. So we're actually checking on your pet about every 3.5 years. So we really labour the point about understanding that the physiology and the physiological aging of our pets is compressed dramatically, and we can work roughly, of course, off that idea that our pets will age, around about every 7 years for every one of ours. So if we're doing a grade 1 pro every 6 months, we're actually doing it every 3.5 years, and we find people accept that that concept really very, very well. Every patient we start with a checkup 1 week post-treatment. Now, if they've had grade 3 or 4 disease, we really want to have a good look in there and make sure that that things are healing up well. There may be sutures and sutured wounds that we need to check on. And in the patients that are grade 1 or 2, it's simply an opportunity now to get them started on a preventative program, because it's really important that we do that as well. We're not doing our job to not get some form of prevention in place. So again, this is all about setting expectations. Now that we've achieved ideal oral health, let's put a program in place to slow down the rate at which it recurs, because guess what? It started to come back already. And an important one that I learnt some years ago at the Veterinary Dental Forum in the US, and one of the specialists put this very beautifully when he said, it's a normal physiological process. So we don't want clients thinking that they're doing something wrong or there's something wrong with their pet. Plaque and tartar development is a normal physiological process. The key is how quickly is it going to return. The reason why we do the checkup 1 week post-treatment is we run the risk of information overload. If we try and explain everything we've done during the course of the day and get them onto a preventative program and set their expectations about how this is going to look moving forward for the rest of the pet's life, it can really be quite challenging for a client to take on all that information. So what we've found is if we give them a full and thorough report of what we've done today, we do take pre and post-treatment photographs with our iPad to show them to the client. If we take radiographs, we show those as well. And then we set the expectation of what things are going to look like with 6 monthly checkups and future treatments. And then a week later, we can then really delve into some or what forms of prevention are going to suit the patient and the client. And that's a fairly significant conversation itself, because what's going to work for the patient is going to be very dependent on the client, their commitment, their time, and so forth. As I said, very, very important to set expectations. Okay. I don't have the luxury of a patient that will sit back, open up and let me poke around to see what's really going on, unlike your dentist. So once I have your pet anaesthetised, I will start with a thorough oral examination to accurately assess the extent of disease. If there's anything unexpected, I will call you immediately to discuss what needs to be done. And that's very, very important as well. We find that the most common situation with grade 1 diseases is that is the limitation of their disease, but certainly we will get cases where we do find bits and pieces. We might have missing teeth, we might have a mobile tooth we weren't expecting, so we need to be able to contact the client because that's going to change things quite quickly. And then of course with grade 2, 3 and 4 disease, well, that can be like opening a Pandora's box. So we really need to be able to get in contact with the client to accurately advise them of what needs to be done. I'm going to up the speed a little bit here because I'm just looking at my watch and recognising that I'm going to run out of time really quickly. So I'm just going to step it up a little bit. Of course, we can have the questions at the end, but there's still quite a bit to get through. So if we look at the grade 1 prophy in terms of how we charge that, if we just look at the hard costs first up, you can see there hard costs to ourselves roughly in terms of pre-medication, IV catheter and fluids, general anaesthetic induction and maintenance, prophy cups and paste, and nurse to monitor that patient. Roughly in this day and age, our hard cost to us would come to about $44.50. What do we charge for grade 1 prophies? Now again, this is totally up to you and your practice. Presently we charge $2.99 for dogs and $2.49 for cats, and then I've moved on to or included an ex-GST figure there because they're the ones that we need to work with if we're starting to look at how do the numbers stack up for us from a business perspective. So if we just look at some numbers here, if we said if you were to recognise and treat just 1 dog per day and 1 cat every 2nd day, and I've said let's just talk about 5 days a week because what our opening hours and what we do on a weekend may vary, so we won't even talk about the patients we see on the weekend, and we'll just talk about 50 weeks of the year because we do lose a little bit with public holidays and so forth. So if we just looked at 1 dog per day and 1 cat twice or every 2nd day, then at that kind of pricing, you are looking at an additional net of around about $75,000. And this is, again, what I'm talking about from a business perspective, not just actually looking after our patients as best we possibly can. What I will add, though, over the past 7 years, it's been our experience that approximately half your patients will require treatment again within 6 months. So to look at it on an annualised basis, it's actually $75,000 times 1.5. So with one dog a day, one cat every second day, you are adding $112,500 to your bottom line. Now, the question that I get asked, and it's a very good question, is, yeah, okay, you've talked about costs there, but you haven't included a veterinarian or a veterinary nurse / technician actually performing the dentistry. And the reason why I haven't done that is because they're there anyway. So do you want your team generating income for you or not? So really, you've already paid for them. They might as well be being financially productive while they're there. I've also had, when I've given this presentation live, and I've done that on many occasions all over Australia, I've had 1 or 2 people say, well, look, you know what, we just can't do that because our vets are too busy, our staff's too busy. And my response to that is, well, how are you going to grow your practice? If you are at full capacity with your human resources, then you are absolutely sabotaging your own growth. You've got to have some capacity there to grow. So if we work on an assumption that we do have some resources, and if we don't, we need to get some, because otherwise we can't grow our practice, and that those team members will be there regardless, then let's have them being financially productive, and let's deliver the best standard of care to our patients as we go. And again, it comes down to as simply as, if you had plaque and tartar and your dentist was happy to wait till you had gingivitis, would you be happy with that? And really, it should be no different for our patients. So that gives you some appreciation around just how critical and how powerful this is from a business perspective. If we look at some key performance indicators, if you want to get a handle on where you are now and where you could be, if we look at dentistry as a percentage of total income, and when we say dentistry, we truly mean dentistry. We're not talking about general anaesthesia that goes with dentistry. We're not talking about hospitalisation, medications. We're talking strictly dentistry. Now, to clarify, when we bill a grade 1 dental treatment, that does go purely under dentistry, just to make sure we're comparing apples for apples. But if we're doing a grade 2, 3 or 4 treatment where there's a component of anaesthesia and hospitalisation and medications, all those other things, theatre fees and so forth, that is all separate of the dentistry. The industry average in Australia presently is about 1 to 3% of total income. We presently operate at 10.4% of our total income. And that would be where the high performers sit, somewhere between about 9 and 11% of their total turnover. What that means for us in terms of numbers, we do a little over 600 dental cases per year. What that means is, I should also add, that's not all. In our first 3 years alone, our product sales rose by 58% because now we're focusing on ensuring we get every patient onto a good quality, ongoing preventative program as well. So that's what our treatment room looks like at Eastport Veterinary Hospital. That's what it looks like on many days of the week. We have 2 dental units operating at the same time because we simply can't keep up with the amount of dentistry that we do with 1 unit. So that's the culture of our practice. That's simply how it looks. Of course, we do everything else as well that we all do in small animal practice. But from a dental perspective, that's simply how busy it is, adopting this level of care for our patients. Okay, so as we move on to the next part, so we understand now the grading of periodontal disease. We understand that if we're not treating grade 1 disease routinely, then we're really not looking after our patients and our clients adequately, and we are missing quite a massive business opportunity, just looking at those numbers that I've shared with you. The next piece of the puzzle is and I should add with that, of course, not only do we require that addressing periodontal disease at the grade 1 level, but we need to recognise the importance of intraoral examination. And if you're still feeling a little bit uncomfortable about, oh gee, should I really be anaesthetising a patient to clean their mouth, then wait till you start doing oral examinations and seeing how many times you will find pathology that you weren't expecting. It's a bit like practices that embrace pre-anaesthetic blood screening. You don't know what you don't know. So you don't realise how many abnormalities turn up in apparently normal patients until you actually go looking. So what you'll find is once you gather some momentum and some experience with this, you'll become totally comfortable in selling, in inverted commas, the idea of a grade 1 prophy purely on the premise that your pet needs an oral examination in an unconscious state. So moving on now, do you need intraoral radiography? And what I'm hoping to do in the next 15 minutes is help you get to a place or mindset where you would recognise that without intraoral radiography, you are simply negligent in dental practice. And I want to add to this too at this point, I guess, that this is something that I and my practice has embraced in the last 8 or 9 years. Prior to that, my dentistry, the dentistry we performed, was terrible, like it is in so many practices, or has been in so many practices, and that is simply because our training was inadequate in that area. Our knowledge and our skills certainly weren't up to speed, and we didn't have the equipment like intraoral radiography readily available to us like it is today. It was always there, of course, but not to the extent that it is now. So I'm really coming from a place of self-improvement and not wanting to sort of stand up and try and convey as if I've ever been any different to all practitioners that graduated and didn't get great training in veterinary dentistry. Okay, so we could look at a list of indications for dental x-ray, but it's a bit like a textbook, and to be honest, I don't think that really hits the mark. I don't think it's compelling, and you can forget that fairly quickly. What I would rather do is to share some cases of ours with you that I think would be probably more compelling and have a more or a greater impression on your decision to use or not use intraoral radiography. So this patient here, looking at the right maxillary fourth premolar or the upper carnassial, there's on oral examination, there's a 5mm periodontal pocket detected at the distal aspect of the distal root. Now, just to get our terminology correct, in dentistry, when we talk about moving or looking at the forward aspect, so cranial or rostral, that is mesial, and then caudal is distal. So the distal aspect there of the distal root is, if you like, the caudal aspect of the tooth. And so there's a 5mm pocket there. Normal gingival sulcus depth confirmed around the rest of the tooth with a periodontal probe. So what do we do? What would you do? Well, I'll share with you what I would have done in the past. I would have got the ultrasonic scaler in there and given a really good scale and polish, particularly around the distal aspect of the tooth there, where I could get the probe up a little bit higher where that attachment loss existed. However, a radiograph of this tooth reveals a grade 3 furcation exposure. Now, furcation, of course, is the space between the roots of multi-rooted teeth, and a grade 3 exposure means that it's through and through. In other words, alveolar bone has been lost to such an extent that there is now a passageway from one side of the tooth through to the other. And when you look at the alveolar bone between those roots, you can see that area of black. And you imagine the impact that has on a client when you say, see that black spot there? Well, that's been eaten away by infection. That used to be bone there. It has a huge impact on clients, and I promise you won't have clients complaining about what they've just invested in their pet's good health. You've provided they will be thanking you and showing enormous gratitude for taking the time to look deeply and really sort out the problems that are going on. Okay, what would you do? A persistent deciduous left maxillary canine tooth. Fairly common, especially in small breed dogs, very commonly identified around the time of desexing. Okay, what would you do? Well, what I would have done in the past, I would have advised the owner that tooth should be extracted. At the time of dissecting would be convenient if it doesn't fall out beforehand. And at the time of dissecting, I'd do a quick extraction with the nearest elevator. I'd almost invariably break that tooth because the roots of these teeth are very long, thin and fragile and easily broken, and potentially causing endodontic and ongoing orthodontic problems that I was blissfully unaware of. Of course, I wouldn't then see that in a year or two's time either, because the patient can't then come back and say, hey Gary, you screwed up. My teeth now hurt. They will live in silence forevermore. So if you think, well, you know what, I've been doing it all my career and never had a problem, guess what? You don't know what you don't know. And the only reason you haven't had a problem is because your patient hasn't been able to articulate it to you. So what really do we need to do here? We need to take a radiograph first up, because we need to know what this root structure looks like. That root may be largely resorbed, and it may be that we can perform a relatively quick extraction on that tooth. However, the root could be entirely intact, in which case we need to perform a surgical extraction. That was the case here. This root is intact. It does require immediate extraction because the deciduous tooth will start to impact the eruption pathway of the adult tooth almost immediately, and that could lead to a traumatic malocclusion. We could end up with the two opposing canine teeth contacting each other, and that could ultimately result in pulpitis and endodontic disease in one or both canine teeth. So in this instance, we actually need to open this up surgically, small flap, take away a small amount of alveolar bone overlying that root, extract it in one whole piece, and then one or two sutures to close that down. Okay, feline tooth resorption, very, very common. We see it all the time. I don't know how on earth you could possibly treat these cases without taking a radiograph. The reason being that with type 2 resorptive lesions, and we won't go into the technicalities of type 1 and type 2, but with type 2, which is by far the most common type of resorptive lesion, we will see varying levels of ankylosis and loss of the periodontal ligament space, and in fact loss of the root itself. So in terms of making a decision about whether we extract this tooth or whether we can perform a crown ablation with intentional root retention depends entirely on what's going on below the level of the gum, and of course we have no idea without radiography. So yeah, do we extract the tooth via a conventional technique, or do we perform a crown amputation? In other words, leave the roots, because the roots don't really exist anymore. It's what's termed ghost roots. If we have a look, the mesial root in this case was ankylosed and undergoing resorption, allowing a partial crown ablation. However, the distal root is intact and requires complete extraction. So there's a bit of both going on. You can see there in that radiograph, the forward root really is now just a ghost. It doesn't exist anymore, and if you try and extract it, you can't, and yet we still need to extract the more caudal or distal root there. What would you do? There's a small fracture of the right mandibular canine tooth in this cat. There was no periodontal pocketing or swelling, so let's keep an eye on it. Let's face it, the mandibular canine is a difficult extraction. Do we just leave that? Do we say, okay, there's a fracture there, but everything else seems to be okay? This was a real eye-opener in this case. And when you look at this radiograph here, you can see the profound bone loss that has resulted from periapical periodontitis and abscessation that has resulted from infection following the fracture. And that tooth got infected because it was a complicated fracture. In other words, the dental pulp was exposed, and we know that within 48 hours of exposure it's going to become infected. What's frightening about this tooth is that when you look at the pulp chamber of the two canine teeth, you can see the massive difference in the diameter of those pulp chambers. Now, the dental pulp or the root canal should get smaller and smaller as the individual ages, because tertiary dentine tertiary dentine is laid down over the lifetime of the patient, making the root canal smaller and smaller. So what we know about this tooth that you can see here that was fractured it died shortly after and its development was arrested. So this problem has been going on for many, many years for this cat, and I can't believe anyone could think that that wouldn't have been causing very, very significant pain for this patient. However, without radiography, we are blissfully unaware of what's going on. Do you really need a radiograph for a planned extraction? Now, I threw this one in because this happened just the other day. When you look at the second premolar tooth there, the mandibular second premolar, you can see that that crown is very flat, and that is because there is a small fracture of the tooth. So based on the presence of a fracture, we decided to radiograph the tooth with the view to potentially extract. And if you have a look at the root of that, and that distal root, or if you like the caudal root, that is something you could never possibly predict a root looking like that. It looks like a crooked dog leg, and therefore how are you going to successfully extract that tooth without breaking the root and most likely leaving some root behind, potentially causing problems down the track without first knowing what it looks like. So you don't know what you're facing with an extraction until you get good vision on the root structure of the tooth. Finally, this is not one of my radiographs. I've taken it from the Veterinary Dentistry website, and that is, don't forget, we do see attrition often. Now, in most cases of attrition or wearing of teeth, the tooth will lay down tertiary dentine and continue to protect the pulp chamber from damage. However, it doesn't always happen that way. This is a case of a dog with chronic flea allergy dermatitis that had worn down all its mandibular incisors, and when you look at the corner incisors, the left and right third incisors, you will see that the root canal is far, far wider than the other incisor teeth, and that is because those teeth have undergone endodontic disease and death due to the chronic trauma and pulpitis caused by the dog defleeing itself commonly. So worn teeth need to be radiographed as well. So when thinking about things like how do I extract this persistent deciduous tooth, the patient has a resorptive lesion, be it cat or dog. Can I amputate or do I need to extract? Whoops, I fractured the root during extraction. Did I get it all out? I have a discoloured tooth. Is there any signs of pulp necrosis? This tooth has an uncomplicated fracture. Is there any sign of secondary endodontic disease? Which tooth or teeth is causing this draining sinus? Anyone ever looked at the classic carnassial tooth root abscess and really not known whether they only need to extract one tooth or more, because we don't really know what's going on without a radiograph? Is the tooth really missing? If a tooth is apparently missing, we need to know whether it is truly missing or whether it is in fact an unerupted tooth, because we need to monitor those with the risk of dentigerous cyst formation further down the track, which can cause significant problems. And with any oral mass, we need to know from a prognostic point of view, is there bony involvement? So that is just a very quick snapshot of cases that would highlight the absolute requirement for intraoral radiography, as well as some of the questions that you would ask yourself and where you would need intraoral radiography in terms of being able to answer those questions. Now, from the economics of, and I say now, of course, digital dental radiography, because you wouldn't consider anything else, in fact, probably nothing else is available anymore. Setup costs, you're looking at about $17,000 to set up with an X-ray intraoral generator and some form of system for producing images, and I would be recommending a CR system as opposed to DR. And the reason why I recommend CR is because you really appreciate having different size plates to work with within the mouth, and DR sensors cost thousands and thousands of dollars, whereas a CR receptor costs a couple $100. So it's a much, much less expensive way of getting a variety of receptor or plate sizes to work within the mouth. Also, when I was in the US at a recent dental forum, I had the opportunity to look at and compare the various options available, and the CR stacks up very, very favourably. I think, to be honest, better than the DR systems, but certainly, if not as good as the DR systems. So what does that mean? We're looking at on a 3-year lease with no residual, looking at about $140 a week. So if anyone says they can't afford it, they just need to think a little bit and look at the numbers. Ongoing costs are effectively just about nil. Professional fees for the client, charge what you like. Obviously, again, in alignment with your practice, we charge $60 for the first film and $20 for each one thereafter. But to be quite honest, and if you look, you only need to be taking a couple of radiographs per week, and your equipment is being paid for. But what's really important here, I mean, in our very first 18 months, while we were still getting good at it, we took 301 exposures, which was a direct additional revenue of nearly $13,000. But far, far more importantly, what you need to understand is that the real gains financially are not from the x-rays themselves, but it's from the pathology that you will find and the treatment that you will do from finding that pathology that you didn't have or you didn't know existed before. So that, if you like, that $450 dental or $550 dental now becomes a $700 to $1,200 dental, and that's the real difference. So I can promise you that intraoral radiography will pay for itself in spades extraordinarily quickly, and to be honest, from a clinical perspective, even if we forget about the numbers for a moment, even though it's a no-brainer from a financial perspective, just from a standard of care, you really cannot perform dentistry without intraoral radiography. That is the simple truth, and I hope those series of cases that I've collected, and look, I could show you hundreds more. They were just a good variety of cases that you could use for teaching purposes to persuade practice owners that they absolutely need intraoral radiography. Another way of looking at it, and this is just a simple example, this was a comparison that I did a couple of years ago of taking the old school approach of saying, okay, I'm going to dissection the dog and I'll perform a quick extraction at the same time, so I'll add on a couple of units of extraction to the desexing, versus just shifting things around and saying, the reason why I'm anaesthetizing this patient today is because it has a persistent deciduous tooth. As a matter of urgency, we need to remove that tooth, and if it's convenient and the patient is well, we will perform the desexing at the same time, and we'll charge accordingly. And just in that simple example, and everyone's numbers, of course, will be a little bit different, but just by changing our approach, in that instance, we add nearly $400 to the bottom line, and we're doing the right thing by our patient and by our client as well. So, final thing, I often ask practice when I'm working with them in terms of dentistry, or in a leadership capacity when I'm working with practices in terms of, you know, introducing a new policy, procedure, program, concept, what's the timing look like? And it's amazing how often when I ask practices, do they do dental month in August? Yeah, we do. How did it go? Oh, it went really well. And then what did you do in September? Oh, well, we stopped doing it. The reality is pets' dental health any less important in September or October or November, any other month of the year than August? I do not understand. It defies logic as to why we would. I understand why we focus in one month, but let's not stop that focus, because that promotion and prevention of dental disease and promotion of dental health is important every day of the week, every month of the year. So I always say yesterday, today, tomorrow, next week, persistently, continuously, and never ending. And that needs to be part of the culture of the practice as well. So tying up, the bottom line is, by introducing a new culture to dentistry within your practice, you will ultimately have healthier patients, you will have happier clients. Just remember to show them why they're happy. And a good saying there from Chris Newton is, make the invisible visible. So in order to demonstrate great value to clients, you need to make the invisible visible. You need to show them before and after photos, and as I said, that is most simply done with an iPad. And if you take radiographs, you need to show those to the clients as well, because they will have a profound impact on how the client feels about what's going on. May I say, having done thousands and thousands of photographs, even at the grade 1 level, it is a very, very impressive before and after photograph when you show those brown, dirty teeth with a bit of redness in the gums, and then these pristine teeth with a little tiny bit of hemorrhage where those gums were irritated, reassuring the client that the gums will be perfectly healthy by tomorrow. But the before and after is most impressive. So you end up with very, very happy clients as long as you deliver the message and set their expectations very clearly. You'll have much more contented staff. They'll feel very good about what they're doing because they're practicing at the contemporary gold or best standards, and ultimately, as I've shared with you, it will have a profound impact on your bottom line profits. So it really is a win-win for the entire team, your clients, your patients, and for the practice owners, for yourself. And that brings me to a conclusion. So I guess I would now hand back to Lauren and Jeanette to facilitate any questions that we might have.
Okay, we've just got our first question here. Hi Gary, thanks for the webinar. We have a CR7 dental radiograph system and find the software very cumbersome. Have you had any upgrade of the CR7 software yet, and is it much of an improvement?
Okay, I actually use the CR35, which uses the same software. I'm not sure by what means you're finding it cumbersome. It may be relating to sharing images with clients perhaps, or maybe it's just the time it takes to process films. I'm not sure. In terms of sharing the information with clients, what we do is we pull the film up on the monitor, take a photo with the iPad at the end of their patient photographs, so that we can show the entire case visually to the client in one nice little presentation. So just with an iPad or something similar, some form of tablet, take a photograph of the radiograph up nice and close. They'll come out crystal clear, and you can share that information with the client. If it's cumbersome from the point of view of processing the films, then that's maybe a conversation to have offline. It certainly slows down, taking intraoral radiographs slows down the procedure, and so I think it's a case of rethinking dentistry in terms of how long does the procedure take, because you simply can't you can't perform the procedure without having that information. If it's more around the taking exposures themselves, I think that's largely a practice thing. I tend to try and forget about bisecting angles and the whole physics behind it. What I have developed is simply the angle of attack that we require for each area of the mouth. So, for example, if we're radiographing the maxillary incisors and canines, our angle of attack is 70 degrees. Forget about bisecting angles and whatnot. If we're doing maxillary premolars and molars, it's 45 degrees. And let's face it, even then, it's all a little bit ambiguous, because who can actually hold a machine at exactly 45 degrees anyway? So that component of it comes down to practice. I have to say we're very happy with the CR system. It does work well for us, but you've got to factor in the time to actually process those images and have a look at them.
Okay, Steve's also said...
I might add...
Sorry, Steve said, not very user-friendly and also sharing is cumbersome, but the iPad is a good tip. Thank you.
Yeah. So definitely take a photo, show that to the client, and that will just sort of streamline the sharing of the information with the client. We don't attach the radiographs to our patient file in our practice program. We just leave it in the CR software, and they're just all filed in alphabetical order there, as you would know.
Okay, that's all the questions we have at the moment.
Okie dokies. That's easy enough.
Thank you very much, Janet. It's really, really great.
Okay. Well, look, I'm easily enough contacted. If anyone did have follow-up questions for me, I'm very, very happy to answer them. I hope that has been of help for everybody and provides a bit more clarity on dentistry in their practice. Lauren, if I may, I just wanted to mention for everyone to jump back on board on Wednesday the 14th of October for the next webinar in this series. That's at 7:30 on Wednesday the 14th of the Good Medicine is Good Business series. And that's going to be presented by Fritz Wood, who's looking at the top 4 growth areas today. So looking at we need to ensure that when we are focusing our very valuable time and effort on things, we want to make sure we're looking at the right things, what's attractive, what shows us or provides opportunity, and so Fritz is going to explore his approach to that and then look at the 4 categories that are really ready to go for growth in your practice right now. So jump on that one, don't miss it.
Excellent, thank you very much.
Thank you very,
That's
very
a pleasure.
much. Great.
That is a pleasure.